student learning outcomes were that students will apply concepts learned about hypernasality and cleft palate to create a lesson plan for a client demonstrating these difficulties. Students will familiarize themselves with tools used for hypernasal clients, and students will familiarize themselves with oropharyngeal insufficiency, which is also BPI, and techniques used to correct it. So our client is Nicky Nasal, and he's a 7-year-old boy who was born with a cleft palate and presents hypernasality upon speaking. A cleft palate is a deformity in the structure of the palate, and hypernasality is an abnormal resonance in which the soft palate is unable to close off the nose from the mouth. This results in air escaping through the nose during speech, which can be seen in individuals with a cleft palate. So common symptoms of hypernasality is when non-nasalized sounds such as P, T, K, G, F, D, and D become nasalized. And BPI is a term used to describe a structural deficit that prevents a sufficient oropharyngeal closure. And there are some surgeries that are used to correct this.
SLPs do not perform these surgeries, doctors do. However, as an SLP, it's important to know these surgeries because we work as a team. One surgery a doctor can perform is the cleft palate repair, which is performed anywhere between 9 to 18 months, and it closes the palate in 3 layers. The first layer, the outer layer, is the nasal lining. The middle layer, or the muscles at the back of the palate, and the inner layer is the oral mucosa, which is a membrane lining on the inside of the mouth. Another surgery a doctor can perform is the pharyngeal flap, and this is when a flap of muscles taken from the back of the throat, and it's attached to the soft palate. Injection pharyngoplasty is the injection of calcium into the posterior pharyngeal wall, and the purpose is to augment the posterior pharyngeal wall. Well, after surgery, speech therapy is needed to learn how to control the newly constructed cavity. Oropharyngeal incompetence, also known as BPI, is a neuromotor disorder resulting in the improper closure of the velopharyngeal sphincter, or the soft palate muscle, in speech. And this allows for air to escape through the nose instead of the mouth. One of the ways to assess an individual with hypernasality is to place the mirror under the nostrils and watch for mirror fogging during the production of non-nasal sounds. One treatment used for hypernasality is the continuous positive airway pressure, also known as CPAP, and it's a treatment intended to strengthen the muscles of the soft palate. It's achieved by providing constant or continuous resistance with air pressure against the velar muscles during speech. Muscles become strengthened due to the fact that it must overcome the additional pressure, increasing the ability of the individual to maintain velopharyngeal closure when needed for speech.
Another treatment method is exaggerated articulation. This is increasing the range of motion of the articulators that will help to increase the palatal closure with more muscle movement. A slower rate of speech also improves velopharyngeal closure and coordination. Visual feedback, another form of instrumentation that we found that was useful was a nasometer. The nasometer is a computerized assessment instrument which measures acoustic energy in the oral and nasal cavities during speech. It's a non-invasive headset, which you can see on the picture there. It just fits right over top, and it'll read the child's air coming out of their nose. But it provides visual feedback of nasality in the client's speech. Okay, you would present something on the screen, and the child would say that line, and if there was nasality, maybe the child doesn't feel it, but they can see it right on the screen because the graph would look a little different. It elicits a nasalence measure, and a nasalence measure is a ratio between the vocal tract's oral and nasal resonances. And we found a little video. Well, it's actually 6 minutes, so we're not going to show the whole thing. We'll just show a minute of it. But it's a video on how to use the nasometer. So pretty much in the beginning of the video, they're just showing you different parts of the equipment, and she cleans the equipment off. To do this, which is recommended, just use a little alcohol swab, wipe it down. Don't wipe it on the actual speaker's part, but I would say around 4, yeah. Here she
anything that
is
touches the
wiping it
patient's
off.
mouth. Make sure that you don't touch the speakers with the alcohol wipes. Okay, and then these knobs loosen so that you can fit it appropriately. So make sure the knobs are somewhat loose before you put it on, so that way it's easy to adjust while you put it on. So you're going to start by placing the face mask part right in between the lip and the nose. And then place the forehead band right on the forehead and Velcro the back part. And then first you want to tighten the knobs to adjust it to fit the front and the back of the head. And then these knobs that keep this part secure. And then you always want to make sure that it's not too tight. So does that feel okay? Mm-hmm. Okay.
It's very secure.
Okay. After the head.
Alright, so for our lesson plan, we included the nasometer we were going to play like a Jenga game, maybe where like if you put conversation starters on a Jenga piece and they like pull it out, so the clinician would say, for example, what's your favorite, tell me about your favorite movie. So then you would have the client answer, and it would present on the screen to show if his sounds that weren't supposed to be nasalized were nasalized. Also, you could already have it set up where you just have certain words to present in the screen. You could choose non-nasalized words like ticket or cupcake and do the same procedure. Another type of therapy was tactile training. You can feel for nasal airflow from the nares on the hands, or you can feel for vibration on the sides of the nose for voice consonants. And we also included this in our lesson plan. Just by having the child feel for it himself when making non-nasalized words, or the clinician doing it also. And here are references. And I just want to point out something real quick. On our handout, at the bottom here, we have like a resource. It's the cleftline.org. It's for the Cleft Palate Foundation. This was a really great starting point for us for our project, but it also is good to know as a clinician because it has a lot of parent articles, pamphlets on how to help develop the speech of your child, or just on what's going on for parents who might not understand or even have dealt with a cleft palate situation before. So I just thought it was a great resource, and even for us as health providers, there's a whole section on speech development, so it's something interesting to look at. Does anybody have any questions? No? Thank you.